people are just clicking on.
Hello? Oh, okay. So the screen is frozen, right?
Yes.
Yes, we're going to get started in about 1 more minute as people join.
Perfect.
Hi, we're about to get started. If everybody can just make sure that their phone lines are muted. Okay. Hello and welcome to today's consortium call that's focused on international perspectives on home visiting. My name is DeMeo Cook and I'm hosting today's call with Sarah Mancall from SRCD. Sarah's providing the technical support throughout the webinar, so you're going to see her name in the chat and probably hear her jump in, especially as we have any problems with the technology or muting. Hi Sarah, can you hear me okay?
Yeah, loud and clear.
Okay, great. So before we begin the call, I'm going to spend a few minutes just orienting you to the GoToMeeting technology. On your screen, you should be able to see slides, which right now there's just one slide that says University-Based Child and Family Policy Consortium on it. You should also be able to hear the call either through your phone, your microphone and your speakers, or you could have called in through a landline or cell phone. So on the right of your screen, to the right of the slide, there should also be a box that has the name of the other people on the call, and at the bottom a chat box. If you don't see that, you might see a smaller box that has a red arrow at the top. If you click on the red arrow, that will bring. If you have any trouble seeing this or looking at any of these pieces, please feel free to use the chat to let me or Sarah know what you can't see and what's going on. You have the option in the chat box to send a message to the audience. You should see something that says all, entire audience, or you can use the drop-down menu to send a message directly to somebody else who's on the call. Okay, and we're going to ask that you try out the chat box in the next few minutes to just say hello. Let us know your name and what university or organization you're from, and that's just a good way to test out the box and let people know who's on the call. Great. If you haven't done so already, please mute your computer or your phone. This will help with background interference, and there will be time during the question and answer period where we will open up to be able to ask a question. Today's call will be recorded, and it will be available on the consortium website. We will also be sending out a number of materials after the call, some reports and just like you to have. We know that many people today are new to the consortium, so we're going to give you a quick overview. Sure. Eric, can you just move that slide? It looks like it's going.
Sure, I'll move it right now.
We go one more. Okay. The University-Based Child and Family Policy Consortium is a forum of more than 35 university-based entities. We have members across the country who represent schools, departments, and centers that all advance the study of child and family policy.
My headphones.
Oh, we could just make sure that everybody is muted. Great. So the consortium regularly hosts monthly webinars and calls like the one you're on today. It also organizes pre-conferences at SRCD's biennial meeting, issues a newsletter, and runs an active listserv that helps connect students, staff, and faculty to professional development opportunities. If you're not yet a member, of the consortium, you can contact Sarah, who is the consortium coordinator, to find out more information and to make sure you get on the listserv. Sarah is going to share her email with you all in the chat and on the slides today. Great. Sarah, if you can go to the next slide. There we go. So today's call topic grew out of a growing interest in international child policy issues and a call series that took place last year that was moderated by Dr. Joan Lombardi. This slide gives you a sense of some of the speakers and topics we covered last year, and we're really excited that these are all on the website and you can view the recordings if you're interested in these calls. So now it's my pleasure to turn this call over to Dr. Joan Lombardi. Dr. Lombardi is one of the nation's leading experts on child development and social policy. She is the former Deputy Assistant Secretary for Early Childhood Development for the U.S. Department of Health and Human Services, and she currently serves as advisor on national and global child development issues. Welcome, Dr. Lombardi.
Thank you very much, Kyle, and thank you for all of your work and the work of SRCD to put this together. Today, we're really very excited to have this session focused on and reflecting the tremendous interest across the world on parenting and family engagement. That interest is emerging for a variety of reasons, many of the same reasons that we see here in the U.S., an interest in maternal and child health, especially now that more children are surviving, trying to help them thrive, interest in early learning and violence prevention, and all of the other driving forces that are putting a spotlight on the parenting and family support movement around the world. There are several strategies that are emerging and a lot of research that is coming from Pakistan, from Colombia, from Jamaica, from Eastern Europe, all around the world on several strategies. Today we're going to talk about home visiting, but I just want to say a few words that there are also group programs emerging, programs that integrate parenting into health and nutrition delivery systems, into conditional cash transfers. So this today is just the tip of the iceberg. We are very fortunate to have two terrific speakers with us today that I'll introduce in a moment. The way we will run this session is each one of them will present and then we'll open it up to questions and discussion. Several people have already sent in questions that we're really excited about. Before I introduce the speakers, I should say that we are also hoping to be able to open this webinar up to the researchers that are doing the work around the world. Our technology is not there yet, but we soon hope to do that. So for today, let me turn first to Dr. Jon Korfmacher. Dr. Korfmacher is Associate Professor at the Erikson Institute. His research focuses on different responses of children and families to early childhood intervention. His recent research projects have included work on home visiting both in the United States and globally, and we're very excited that Jon was able to be with us today because he is following the networks that are emerging around the world. After he speaks, we'll turn to Dr. Kim Boller, who's a senior fellow for Mathematica Policy Research and director of research programs focused on young children both in the United States and abroad, including supporting evidence-based home visiting to prevent child maltreatment. We all know the wonderful work that Mathematica has done domestically in tracking the home visiting research, and they're moving to do that internationally as well. So with that, please join me in welcoming both speakers. Dr. Jon Korfmacher first. Jon? Jon? You might have to unmute.
Can you hear me now?
Yes, we can hear you now.
Okay. Somehow I got muted. I have control over the slides now?
Yes.
Great. All right. Looking at how I have control.
You should be able to use your arrow key. There you go.
Oh, there we go. Thank you. Well, first I wanted to thank the Child and Family Policy Consortium and to say I'm very flattered to be connected in any way with the distinguished names that have been presented on the earlier slide. I became interested in international work on home visiting after being invited to be a consultant on a home visiting project in Sao Paulo, Brazil. And I found myself fascinated by both the advice that was being given to the program by other members of the advisory committee and by the decisions that the program was making. What was the same as in the U.S. and what was different. So this is a somewhat maybe pithy way of summing things up, but I have found that this to be true, that the problem with home visiting is that there's many good programs that cannot demonstrate how they're good. There are many not-so-good programs that think they are good, and there are many programs in the middle that need a roadmap for how to get better. I've seen this both in my work in the U.S. and now in other countries. And one other problem is that it's not always immediately obvious into which category any home visiting program should go. So we have to be careful with any one-size-fits-all solution, but I will say that a solution is to promote or develop a culture of inquiry for home visiting. I think it's essential that programs that are curious and are reflective about themselves and who have staff that are engaged in thinking about what they do and how to do it better are much more likely to be successful. And so I'm going to give examples from two networks that I am part of that are trying to do just that. I'll be the first to admit that there's a lot that I don't know, and much of my journey here is being confronted by how little I actually do know. So it is both energizing and humbling. I'll talk about my experience working with an advisory group in Central and Eastern Europe, and I will talk about my work with colleagues that my colleagues and I are doing to try to develop a network in Central and South America. Oh, there's the animation. Fancy. One thing that became quickly obvious to me as I broadened my view more internationally is that there's a number of competing agendas at play here that surround the advice and support that are given to countries, and that's focused on early childhood home visiting. So our program interests in violence prevention, health, education, development, or in some kind of combination. Should a community or a ministry or an agency develop a homegrown model that is attuned to their context and culture, or should they implement and adapt a program model that has already been shown to be successful elsewhere, such as in the U.S. or the U.K.? Does this model need to be evidence-based in the way that we're currently thinking about what evidence-based means, meaning participation and results from a randomized controlled trial? There's a lot of pressure from funders and international agencies to use evidence-based practices, which often means taking a model from the U.S. or the UK, although what's exciting is that there are now studies that are emerging from other countries as well. But that always creates its own challenges and tensions when you're borrowing from other places. Do you layer early childhood home visiting into existing services, such as using community health workers, and then try to boost their focus on child development or a relationship-based approach to work? Do you focus only on families you have determined to be at risk, such as teen parents or families in extreme deprivation, or do you try to do a more universal program working with all families? So many of these are agendas that we struggle with in the U.S. as well, so it's good to note in many ways that we're not, that we're all in this together. There have been different attempts over the years to support early childhood initiatives in low and middle income countries. And so here is just a short list of recent initiatives, each which comes with its own agenda or its own frame. And so it can get a little confusing trying to keep track of all of these very well attentioned and typically very thoughtful work plans. Not all of these directly comment on the potential of home visiting, but all are focused on the health and well-being of children. And so just after that brief intro, I'm going to spend the rest of my time focused on the two groups that I mentioned before. First, in Central and Eastern Europe, there's the small but mighty regional office of UNICEF has been leading the way in promoting home visiting in that region. And just by way of introduction, here is a, I'm sorry you might not be able to read this very well, here are the list of countries that are seen by UNICEF as part of this region. As you know might know from reading the news, this is an area with a fair amount of political uncertainty and drama right now. I just noticed, for example, over the weekend that both Turkey and the Ukraine have been on the front page of the New York Times in the last 48 hours. So it's an additional challenge to try to layer a stable system of early childhood services onto countries that may be politically somewhat volatile. The other thing that's really important to note is the countries dramatically in this region in culture, infrastructure, politics, resources. On the other hand, almost all these countries have some kind of public and universal home visiting nursing program, which is often a result of their involvement in the former USSR and its centralized government system. But these systems are not well funded, or often not well funded, and nurses are not always well trained in working with families beyond basic issues of child health and growth. So UNICEF, it's been their idea to leverage these networks and find ways to support building in more developmentally and relationally focused approaches to home visits. And sometimes it's explicitly noted within the country, and sometimes it's only implied, but a primary goal of infusing the home visits with this approach is to prevent institutionalization of children, which is still a fairly common practice in many countries in this region where there are concerns about abuse or neglect. So the regional office of UNICEF put together a technical and advisory group to support this effort, and I've been part of 2 planning meetings in Geneva this past 2 years. There was also a meeting in Turkey earlier that I should have noted on this slide that I did not participate in. Both Dr. Boller and I are part of this group, along with many smart people, and it has led to another agenda. We as you can see, this agenda has some ambitious goals, and which can be summed up by saying that the Technical Advisory Group, plans to focus on the health sector as the main context for home visiting. This narrows the focus somewhat, but it makes a fair amount of sense for this region. The goal is to improve the quality of the nurse home visiting programs and to increase their emphasis on child development and working with families at highest risk for institutionalization or infant mortality. And despite the diversity among the different countries, the hope is to develop a set of guidance documents that have a common set of standards of quality across the region. The work so far can be summarized into 3 main strands. So we have one that's focused on education and workforce development. The International Step-by-Step Association is piloting a program that has online modules and the thought is that you can take generic material online and then adapt it to the specific needs of the countries. And this way you can keep the costs down and you can allow training to be implemented widely across the region, including the remote areas where in-person training might not be feasible. The second thing is a toolkit of curricula and assessments, and I actually wrote this document with the help of a former research associate, and the document provides one-page summaries of different tools with the focus on those tools that are free or cheap, that require minimal training and are available in at least some of the languages of the region, such as Turkish or Romanian. And finally, there's a framework for monitoring, evaluation, and research, and this framework proposes common baseline measurement across countries. And UNICEF has also created contracts for consultation with countries to develop an evaluation plan for their home visiting programs. There's one currently happening, or it might have just recently concluded in Bulgaria, for example. The monitoring, evaluation, and research framework was drafted by Ayşe Usavze. I'm always nervous to get her name wrong. It does a really articulating key principles that directly relate to the point that I made earlier about the importance of developing a culture of inquiry in a program. So in other words, a good MER system can involve all of the staff, is is useful at the policy and the practice level, and is used in a strength-based manner, so it's not used simply to highlight the failings of the program and its staff. And given that my background is in research and evaluation, I am biased, but I really like this approach, and I see this as central to program improvement. So I am going to move on to the other region I'm involved with, the Central and South America. This is just kind of a whirlwind tour. I apologize for that. There are, what's been striking to me is that I am often encountering home visiting programs I've not heard of before in my trips down there. To be glib, you could say that this is a PR program, a PR problem in this region. There's a lot going on that we don't really know about, and it's not always easy to find this information. So a number of countries have placed an emphasis on early childhood development, and in particular are interested in programming that involves multiple ministries or sectors of government, so health, education, justice, welfare. I was just at a meeting in Lima, Peru last week that was hosted by their Ministry of Development and Social Inclusion to highlight their efforts at the federal government level to support development across the lifespan and across the different ministries, what they call intersectorial collaboration. It's exciting to see this, and I think it's an area that we do not see nearly as, it doesn't seem to be nearly as strong in the U.S., although I think McVie, for example, is working hard to deal with this. Another contrast to this than other areas I've seen is that many of the programs here have a very explicit focus on promoting child rights. On the other hand, there is not a lot of evaluation happening with these programs, so it's hard to say exactly how well they are working, as promising as they can seem. And many of the intersectorial collaborations exist better on paper and at the federal level, while the programs are operating at the municipal or community level, and it's unclear how integrated they actually are. So I am just going to give a few examples in this region. My colleagues and I have information on more programs in South America than Central America. Like I said before, we know there's home visiting in these countries, but it takes effort to get updated information. One example is a program in Honduras where home visitors come out of the health department, and much of the home visiting is focused on physical growth and nutrition, but they're trying to integrate child development information into what they do. Then this region includes the Caribbean. Examples of programs here are the long-standing early stimulation program in Jamaica, which just had a 20-year follow-up published recently from a randomized trial that was originally conducted by Sally Grant-McGregor and Susan Walker. The Roving Caregivers program operates out of a number of islands in the region. And also important is Educa a tu Hijo, which is an early childhood service developed in Cuba with a primary home visit. This model is very popular in the region, has been disseminated across countries, including Brazil, Ecuador, and I believe Guatemala as well. There are a number of examples in South America, and all the programs on the left-hand side have a process of being evaluated in an experimental design. I want to highlight, however, two programs from Brazil, the ones that you can see marked in green. Do I not have the controls anymore? Let's see. Oh, Sarah, can you move it forward for me?
Sure, I will do that right now.
There you go. So PM uses Educa a tu Hijo as its base for developing the home visiting model. It's a large program that is funded by the state government. It has over 2,700 home visitors, many of whom are social work students. You can see it has a large number of families they serve. It has a strong focus on parent education and school readiness. A lot of their work is focused on teaching the parents activities that they can do with their child to promote development, somewhat similar to what you see as parents as teachers here in the U.S. The Federal Ministry of Health in Brazil is thinking of scaling it up so that it goes through the entire country. But one issue is that it has not been rigorously examined in a RCT or even a quasi-experimental design. And so PIM is working with McMaster's University in Canada on an evaluation, but it's still in process. And there are other challenges in using this model, including staff turnover, given that so many are students. And so these are issues that the federal government of Brazil is wrestling with as they try to figure out exactly what it means to scale it up. And then, in the interest of time, I'm not going to spend a lot of time on the next model, but I'm just going to use this about FASPIR. But I want to use this picture to represent my 1,000 words. Like PIM, this program is run through it covers a large region, but it's run through an NGO. But this region is in the Amazon, and it is much less densely populated than Rio Grande do Sul. So it's an area the size of Texas may hold only a few thousand families, and it can literally take days to get to a home visit. And I just find this picture remarkable every time I look at it. It's an issue that very few home visiting programs in the U.S. have to deal with. So the reason I know about these programs is I've been developing a network with colleagues focused on supporting home visiting programs in this area. The Pan-American Home Visiting Research Network is a collaboration with my institute and members of institutes in Chile and Brazil. We have a small SRCD planning grant that has allowed us to get off the ground, and although Bernard Van Leer has not directly supported us, they've been generous in allowing their grantees to use travel funds to attend our first planning meeting this past May, which has helped us stretch our limited funding. So I've listed the goals of the network here. In general, we want to shine a light on these programs. We want to identify them to the outside world and to each other so that they can communicate and disseminate information with each other that will be helpful. You know my bias, so I will just say I have a strong interest in promoting evaluation and research strategies that can lead to quality improvement. And as with my work in UNICEF, we would also like to create a toolkit of measures that will be useful to programs. There we are. We had a small and focused planning meeting in Santiago, Chile this past May, where representatives from 10 programs across 7 countries came together to share their materials, their experiences, their common challenges. You can see at the bottom we spread out all the program materials people brought so they can share and compare, and this ended up being probably their favorite part of the meeting. There was a long period where everyone was just crowded around this table to try to see what was similar and what was different across what they were doing. So in many cases, this is the first time that people from these programs and these countries had actually met with each other and been able to talk and share what they were doing. One of the things that was most important for the meeting, I came to realize, is that it was a safe place for people to talk about issues that they were struggling with. And to me, this is important because I've been to a number of events like the one I mentioned in Peru that are very official, that might be hosted by the government, and they invite representatives from programs to talk about their work. And at all these meetings, there's a sharing of PowerPoints, and there's a certain amount of bragging about their program. They're highlighting what is good and great about their program, which I think is great. But then the people go home, and there's no more collaboration after that. And so it also, the problem is it tends to hide real conversation about what things can be done for program improvement. And at our meeting, it felt like a much deeper sharing of what was happening, and people just really kind of struggling with what are the things that they feel that they need to do to make their programs better. Supervision and training is a huge issue in this region. Supervision that is practice-based and goes beyond just simple administration is really not on the radar here, and the programs were very interested in the notion of reflective supervision as a tool for home visitor professional development. There is, as I said, we focused on monitoring, evaluation, and research strategies. they brought up the notion that there is a need for just general indices of child well-being, but that's across these countries, it's not always that well gathered, and so it puts the programs already behind in trying to figure out what they need to do or what their baseline is. And they had the question of, is it their responsibility to collect this data, or can that be a function of someone else to collect that data? A lot of these programs are feeling there's so much effort and attention to early childhood that some of these programs are feeling a lot of pressure to be scaling up as quickly as possible, and that is difficult, especially if you don't have really strong evidence for what parts of your program are working or not. And I think our biggest challenge on a network level is maintaining momentum and moving forward. So I'm very conscious, sitting here in the U.S., that there is only so much that I can do to push the network forward without falling into the same trap that often happens, where regions are simply told to follow the advice of Western experts and practitioners. So, you know, to use maybe an old-fashioned term, how do we support without seeming like we're practicing cultural imperialism? So we're working to use the experience and connection of the people at the meeting to move us forward. We also need to formalize our network, such as developing a working website so that people can more easily find us. So those are kind of our next agenda items. So just in conclusion, I think these are things that I've said before. I'll just list them again, but we want to make sure that we can identify regional experts and partners, and how can we build on what resources already exist. How do we promote monitoring, evaluation, and research without annoying, threatening, or overwhelming home visitors and the administrative staff? This is a big issue in the United States as well. How much consensus do you need within a region? How much agreement do you need to collaborate? And how do you promote real progress versus just tinkering with roadmaps? So what are the steps or the action steps that really will lead to change? And so just my final kind of thought is, you know, networks can be amazing resources for sharing and for connecting, for developing a culture of inquiry and for learning, but it can also be like herding cats. And so you have to make sense of the multiple agendas, and you have to, above all, be very, very patient. And so I thank you for your patience with me, and I really appreciate the opportunity to be able to share with you what I've been doing. So thanks.
Thanks, John. And let me turn it over to Kim.
Oh, thanks so much, John, for setting everything up so nicely here. Thanks for Joan for hosting and for the consortium for inviting me. Joan and I have been running around these black boxes of home visiting, inside of them, mucking around them. There's many of you, actually, who are on the phone as well. So it's really great to be able to talk with you about this issue. What do we know now about this black box of home visiting? How does it work? What seems to be coming to the fore as far as the active ingredients of home visiting? And how can we help, as John was saying, to use research and a real research to practice, practice to research model to bring program improvement forward and bring our field forward? What I'll do quickly now in this brief overview, there's a lot of words on the slides. I'm just going to slalom through these words here for you today, is really talk about our understanding about home visiting and how it works and doesn't seem to work in some cases. I'll reinforce some of the examples that John gave on global networks, describe efforts in the U.S. to document impacts and implementation of 39 different home visiting models, and provide a summary of the evidence of what it means for the field. Then we'll talk a bit about the ideas and methods of implementation science and how they help us globally to think about new paths of inquiry and testing, and provide a framework for learning and CQI with the U.S., Pakistan, and Colombia examples. And then I'll wrap up with some ideas for next steps. This is a quote from Diane Paulsell and a group of us who wrote in 2010 in the 0 to 3 journal in a special issue on home visiting about the issues related to the idea that home visiting is a strategy. And this is something I say often to people. A lot of what gets bandied about at the policy level is a mode of service delivery, like home visiting pre-K, community-based child care. But what I really care about is what happens within those service delivery strategies. And when we're talking about home visiting, we're really talking about what Diane wrote here, home visiting as a strategy that we have to look at the content and focus of the home visiting, the characteristics of the visitors, the targeted outcomes, and how they vary by the different program models people are working with. And what we've been trying to do for more than 6, 7, 8, 10, well, for some of us 18 years, is really trying to understand what's the same, what's different, and what those targets of change are for different models and the key factors that make them effective and not. So this is something we've been trying for quite some time, and it's just kind of nice right now to bring it together with a couple other strands of findings. I wanted to acknowledge the idea of network examples and just reinforce what Jon was saying earlier, the idea of building on, sharing, extending the learning, and about these active ingredients of home visiting. So we see formal networks that are filling this gap with the ones that Jon was describing under the leadership of Deepa Grover and Bettina Schwenthelm in the Central Europe region that supports both early stimulation and child health, as Jon was saying, these how people are creatively combining and responding to the needs and the cultures within their countries and their regions. So these are a set of examples here. The Pan-American one Jon talked about, a domestic one in the U.S. Called the Home Visiting Collaborative Improvement and Innovation Network, and that's under the guidance of Carlos Cana at HRSA, as well as others. Mary Catherine Boller is very involved with that one. And the Home Visiting Research Network. Again, this is more, at the moment, domestically focused, and Jon and Duggan have a very large role, also funded by HRSA. So those are some examples that you can look into as far as networks that you might want to be part of. And then the nice thing about a number of them is that you can just raise your hands and say, I want to participate and contribute to these networks, which is fabulous. Another example I'm just throwing out here is a less formal, perhaps, example of how we share is the National Summit on Quality and Home Visiting. A number of us have been going to that for 4 years or so. I was about to have the 5th one coming up in May of 2015, and that's supported by Pew as well as some organizations and hospitals in Ohio. And I think that we have some folks on the line from Pew who might be able to talk a little bit more about that as well. But we've seen presentations from folks in New Zealand. I've met people there from Australia, other parts of the world who are coming to these events and sharing what they've learned. I want to talk a little bit, in the brief recent history of the U.S. quest for home visiting evidence. Many of you on the call know it, a number of you may not. Trying to understand these implementation drivers, and it goes, from back in again sort of the recent history, funding from the Children's Bureau to look at 17 sites across the U.S. A national evaluation that we conducted with Chapin Hall Center for Children. Deb Darrow there was my co-project director. That just ended in June of this year, and with the system fidelity and cost studies. And again, all of the materials in those I've shared with Deepa Grover in Central Europe. I've shared with Aisha in Aisha Yousafzai in Pakistan. Just as much as we possibly can, as we're working collaboratively, sharing what the resources are that we have, learning from each other to make this process better and better. In 2009, was ACF, Joan, the Office of Planning, Research, and Evaluation, HRSA, really saw home visiting coming to the States and commissioned a project called that's referred to as Home V, a systematic review of the evidence for home visiting. And then the Affordable Care Act included funding for home visiting across the U.S., but there were strings attached based on the Department of Health and Human Services evidence requirements. This led to the Maternal, Infant, and Early Childhood Home Visiting Initiative, MICV, people call it, and its evaluation, which its acronym is MyHope. So that's a lot of information there, but I wanted you to be able to have it so you can go back to it, look up these projects if you would like, and think a bit about the application of this culture of evidence that's been coming along and how it's been influenced by other countries and potentially has influenced other countries as well. That might be a good thing for us to talk about a little bit later, too. So Mathematica holds the HOME-V contract with the Office of Planning, Research, and Evaluation and conducted the systematic reviews based on broad searches of the literature. And I'm not on that project, so I'm just telling you these are the things you can all go onto the website and find yourself. The process is exacting and includes documentation of implementation requirements from the developers and also what was in the research papers on implementation. So research that was not in English was screened out, limiting global input. That's something else we should probably talk about too, the status of journals in other countries and who has access to the research literature there, and other criteria that are listed here. So the real question is, where are we on the evidence based on HOME-V and recent international reviews and papers that are sort of hot off the presses this year? I wanted to note that the evidence reviews done by Mathematica under the HOME-V project have two different kinds of products. One is an identification of the studies conducted with a high bar for rigor, plus a documentation of the size and direction of the impact, whether they're positive, negative, or some combination of them. And if they're then used for funding decisions, the funder also sets the criteria or the bar. For example, maybe the funder will say it's okay if you have one study with at least 2 positive impacts and one with no more than X number of negative impacts, for example. What they found, what's been found in HOME-V is that of 39 different models that were reviewed, and you can go online and get the reports on them, 16 of them currently meet the evidence standards and the criteria for funding by the Department of Health and Human Services. Some are models developed or drawn from other countries, HIPPY, for example. Most are, what we see there is that most of the impacts are in the small to modest size. Some of them have been documented to extend far out, though. Nurse-family partnership is one of them, for example, that has outcomes all the way out to early adulthood. I wanted to mention the Lancet series of 2007 and 2011 included some programs with home visiting components. These are special issues of the Lancet that look at early childhood around the world. I highly recommend folks look at those. And they were led by Pat Engel, one of the four mothers of the Care for Child Development Program, which is the basis for a study that I'll talk about in a moment. I wanted to mention 2 recent impact studies that look at stimulation and micronutrients. And this is something to keep in mind, that these are people who generally are coming more from a health perspective and looking at the combination of early stimulation, what we would call early childhood education and support for parenting, together with health and nutrition supplementation. So as Joan was mentioning earlier, the Columbia trial is combining conditional cash transfers together with home visiting, which is an exciting idea looking at child welfare. And what they found here is that weekly home visits that included psychosocial stimulation did have impacts on cognitive language. This is 1,400 children, 96 towns across the country, so it's a large-scale study. But micronutrients alone didn't have an impact, and there were no interactions between the two conditions. These are measured based on Bailey scores, and that's something to keep in mind as well. The other project I wanted to mention and recommend was published in the Lancet just this year by Aisha Yousafzai and her colleagues at Aga Khan University. This was lady health workers providing home visits, and they found significant impacts at 24 months. These started when the children were 2 to 5 months old, that had the responsive stimulation activities that the parents were that were modeled for moms and shared with the mothers, and as well as there was a condition with enhanced nutrition alone. And again, here where there was an impact when it was the home visits and stimulation, and nutrition alone, but no additive effects of the two of them together. This was also a very large study. But the contrast between the two I wanted to point out quickly is that the Pakistan study is 11 pages, journal pages long, its publication, and has a lot of detail, plus an online appendix about the implementation details of this program. The Columbia study is about 6 pages long, and there isn't much detail about the implementation, the different factors, the different things that were measured, and so on. So I think we want to return to this idea that we have to document implementation a bit more so that we really understand what's going on with these programs. What I wanted to move to now is again, this point that if we don't know what home visiting is, what's in that black box, what matters for quality, what matters for family take-up and engagement and for outcomes, we can't really get to bigger, more meaningful outcomes. So implementation science provides frameworks, and there are many of them out there, that help us in this area. So, for example, what frameworks will do is help us be able to think about the theory of change or the logic behind each of the different models. And again, they're quite different, as John was mentioning. Their implementation inputs, their outputs, and both short and long-term outcomes. Implementation science is really focused on the idea of understanding evidence-based programs, and also informs promising or new programs. That's the other thing to keep in mind. It helps us unpack these black boxes and understand the details of things like participant and staff characteristics, outputs like fidelity of implementation. But I wanted to point out that in a recently published article, Diane Possel and her colleagues, Patricia Del Grosso and Lauren Suplee, took the home V information, had 178 relevant articles on 22 different home visiting models, and found that most of them, the majority of them, are not reporting on something as basic as fidelity. And of those that were reporting on it, it wasn't so clear what the source was or the quality of those data. I just wanted to flash this by your screen. You know, feel free to go a little bit more in depth in it, but this is really an elaborated example. It builds on the work of Ann Duggan and Lauren Suplee. I first saw it at one of the few meetings, by the way, and it was developed for the McV National Evaluation. And what you're seeing here is really, again, that relationship between what do we think is in that black box of implementation input, what's in that black box of output. So, for example, the planned intervention. What exactly does the developer say needs to happen if you're implementing this intervention? Things in the next column, the third column over at the bottom, implementation processes, things like decision-making, strategies for working with external systems, and then getting into the implementation outputs, fidelity, all the different things that we talk about when we talk about fidelity as implementation. So again, how do we've blown up this black box. It's no longer just activities here. It's the implementation inputs and their outputs, very precisely defined. This is an example from Baby Faces, which is a descriptive study of early Head Start. I just want to point you to the third set of bars. The home visits generally are designed to promote parent-child relationships, and you would expect home visitors would say, or we would observe that they spent the majority of their time doing that. But we actually didn't see that in the Baby Faces project at age 1, 2, and 3. Only about 14 to 16% of the time in the home visit was observed to be or reported to be spent on parent-child focused activities. So this, again, gets in the black box. What's happening actually during the visit? I just want to wrap up with a few points here related to what should we do next. I think that a lot of us are, again, focusing on the documentation of implementation, really trying to figure out how to get that into the existing literature. Trust me, it is not very easy. Implementation findings published, especially in our standard early childhood journals. Prevention science, implementation science, other venues are much more likely to support or to allow you the space to be able to document implementation well. I think a continued role for researchers is to help programs manualize and think about why they need to do that with scale up in mind. A few other points here that I wanted to drive home is the idea of these learning collaboratives. It's not easy to do a learning collaborative. It takes a lot of time and effort and resources to do that. And I had a couple other points here as well, but I better turn it back to Joan. After we just take a look at one more thought that I had here, maybe it's not a black box of home visiting, more like a globe, and thinking about our global issues here, where some of the knowledge and processes of quality of home visiting are now more understood as universal. Some are definitely unique by region, country, and are community specific. But then again, maybe it also is the case in the graphic on the right that everyone says we're flying the plane and building it at the same time. And we need to be sure we build on the shoulders of those that have gone before us and those around the world who are trying to make this, make these models better and ultimately affect children and family outcomes. A couple of resources here, and then back to Joan. Thank you.
Okay, thanks, Kim, and thanks, John. I think you can hear from this very quick overview, from both of the speakers, but particularly from John, the wide number of models that are emerging, the networks that are growing, and Kim underscoring the importance of us really focusing now on implementation and understanding the dynamics. I would add that from the examples that both of our speakers spoke about and we have on our resource page, what I think we should learn from the U.S. perspective from the rest of the world is the importance of integrating these strategies with nutrition, with health, integrating them with income supports. So I think that there are lessons that we can learn from the models that are emerging around the world, and I really urge everyone to read the Jamaica study, the new study coming out of Colombia, and the Pakistan study, all of which we'll have up on our website. So we've got several questions that came in. We don't have that much time, but let me start with John. One of the questions that came in is, what are the key components of home visiting that international agencies use in their focus? What are their objectives of these home visiting programs? What are you seeing?
I think, well, most of them have a larger focus on health, but as I mentioned before, it varies quite a bit. Intersectorial collaboration is a big focus, so programs are attempting to be more integrated and comprehensive, but I think in general there's still a lot of programs based on a basic focus on health, weighing the baby, nutrition. There are programs that are also focused on teaching parents activities as a way to promote child development and possibly parent-child interaction. It depends to some extent on which, most of these, in most of the countries, there is one of the ministries is kind of taking the lead for the program. So it sort of depends upon which ministry is taking the lead. It might depend on what emphasis they have.
That's helpful. That kind of reflects what happens here too.
Right.
Kim, what do you see, as the link between home visiting and the larger global child development outcome movement?
Yes, I think that there's a real drive for coming up with universal child outcome indicators. And what I see the contribution here for home visiting, especially early childhood, infant and early childhood home visiting, is a really strong focus on the birth to 3 outcomes, which are often ignored in the larger global picture because there's such a push for primary school outcomes of pre-primary classroom-based programs. So it really feels like what these programs do, as they do here in the U.S., is help us think about how we measure birth to 3 and what the expected outcomes are by when. As you heard in the couple of examples I gave, the Bailey is often the outcome. And again, let's just think about that, right? It's the Bailey, developed here in the U.S., often using U.S. norms. It's, again, a puzzlement to me that, but understandable. I mean, there just aren't a lot of resources developing new measures, but that's really the prime focus. As the other issue is, do countries have baseline information about how children are doing when they're 3, 4, 5, so that comparisons could be made over time, and often that information is lacking.
Thanks, Kim. And I think that if some of you that have listened to earlier calls and remember that we had talked a little bit earlier in the sessions last year about the fact that the World Health Organization is working with UNICEF and UNESCO on outcome measures, including 0 to 3. So somehow our work here and that work has to be integrated. Kyle, do you have any question coming in from the field? Otherwise, I'll with the list that came in ahead of time.
You can keep going, Joan. John's actually been answering some of the questions as they've come in through the chat, so you can answer a few of the other ones.
Are there any, John, just one last one because we're almost out of time, are there common trends that you see across countries in designing home visiting programs?
You know, I think like looking at it was interesting to look at all the program materials at the meeting that we did in Santiago, that they all, I know that's not the same thing as just designing the overall intervention, but I was struck by the similarities, that they all like have this general notion of what, you know, how these printed materials should look, both for the home visitors to use and then for the families to be able to look at them and get something out of them. They're all very brightly colored. They all tend to be like very kind of, they try to use very simple language to try to describe the activities. And I was frankly struck by kind of the commonalities across all of them.
John, if people want to see some of the materials that are emerging, is there a way for them to access material?
That's a good question. I don't know. A lot of them are not available. They're literally like physically printed documents. I can ask some of my colleagues if they would be willing to share, if there are electronic versions that they would be willing to share. But I'd have to find out about that.
Okay, well, we'll look into that.
Yes, I will. I'd definitely like to be able to do that if I can. So.
In my last few minutes, if there's any other of the national models from the U.S. that are working globally that just want to say a few words, I don't know if any of you are on the line, because I know a lot of the modelers that are working here are working internationally as well. We'll try to see if we can connect with them and put some of the materials up that they may be developing or the places they are working around the world. But I think we're just about out of time. Kyle, let me turn it over to you.
Great, thank you. So we're just going to wrap up. I want to thank both of our speakers and Dr. Lombardi for moderating the call today. This was really great, and thank you to all of you for participating. The next consortium call is on Tuesday, December 2nd from 12 to 1 Eastern Time, and it's going to focus on the biological embedding of child abuse with implications for policy and practice. So if you are new to the consortium calls today and are not currently on the listserv, please email Sarah Mancall to make sure that you get the invitation to be on that call. And also, if you have any questions about joining the consortium, about membership, or even just being on the listserv, Sarah is a great resource to contact. So thank you again, everyone, for participating, and we will be sending out follow-up materials, some of the reports and links that our speakers talked about today, and additional information. Thank you.